I'm going to ask Peter and the panel if they do spinal tap and oligoclonal bands for each case of demyelinating optic neuritis.
No, I don't do spinal taps. If the patient has a typical optic neuritis and their MR is either positive or negative, I don't do it. Some neurologists still do it, and I don't know how good the information is. And some of them actually base their treatment on whether the spinal fluid is abnormal. But I don't send people routinely for spinal taps. In fact, I try not to send them to neurologists who will do a spinal tap. But let's ask the neurologist.
Well, as a neurologist, I don't do it if it's clinically isolated optic neuritis. I don't do an LP. Your yield is probably going to be very low, and you put the patient through a procedure that may not have very much in the way of anything to add on to what you're going to do for them. But if I see several lesions, I do an LP to see if there are oligoclonal bands, because that is one more factor in favor of helping me make a diagnosis of MS. So.
Well, I guess as a neurologist too, there is evidence that the presence of oligoclonal banding does have a predictive value, just like the MRI scan does, for the likelihood of developing MS in the immediate future. The problem is it's not an independent source of information compared to the MRI scan, right? It's not like these are they're related. So what we really don't know is whether if you have an MRI negative, whether there's still some additional prognostic information on how valuable that is. I think it's maybe more of an issue if you're on the camp like Peter is, where you're thinking that maybe you want to start interferon sooner rather than later. If you're in the camp that's going to say, well, I'm going to wait until I see what happens next, or I'm going to wait until the MRI in a year's time and see if there's any evidence that this person's got a relapsing problem, then what's the big rush?
In the optic neuritis treatment trial, half the patients received a lumbar puncture. None of those lumbar punctures showed anything other than demyelinating disease. So I think we're all saying the same thing is, I think it's useful in typical optic neuritis for confirming the diagnosis of demyelinating disease. Where I find it particularly useful for oligoclonal bands is when the white matter lesions are not specific and could be migraine or some other small vessel ischemic disease. In that setting, oligoclonal bands helps me to say that those white matter lesions are significant rather than just saying, I don't know what those white matter lesions mean. But I don't think there's any definitive answer to the question you've given.
Yeah, point taken. I mean, the other thing that sometimes happens in our institution, if we're faced with that dilemma, is to do a cervical or spine thing, but which you could argue is a bit more costly, but perhaps a little less invasive for the patient.
In the optic neuritis treatment trial, the patients who received the oral steroids had increased rates of recurrence. Is there any logical explanation for that?
I'm going to pass this right along.
In the United States, in Texas, we have a saying about going bear hunting, which is if you're going to go hunting for bear, you better kill the bear. Because if you shoot and wound the bear, that's a much, much more dangerous animal than if you just left the darn thing alone. So if you're going to go hunting for optic neuritis, I think you've got to kill the bear with intravenous methylprednisolone. There's clearly a big difference between intravenous methylprednisolone, a gram a day, versus 60 milligrams of oral prednisone. So it is one theory is that it's a completely dose-related effect, that 60 of oral prednisone does not equal a gram of methylprednisolone. There are other alternative hypotheses, however, including the first pass effect through the liver, as you know, intravenous versus oral with the oral bypass. And also, there might be something to the fact that the intravenous pulse gets the dose up quicker, and we use that for giant cell as well. So all steroids are not created equal. The dose, the route, and the duration of therapy probably all do make a difference.
Regarding the 2020 patient who cannot read, can this be caused also by migraine prodroma or not?
Caused by what, sorry?
The 2020 patient who cannot read.
Yes.
Can this be caused by migraine prodroma? Because I have two patients like this.
With migraine?
Yes.
Migraine induced, you mean during the time that they have the migraine?
Inducing central hemianoptic scotoma, they cannot read for It's for sometimes, and after this it is relieved. It is transient.
Oh yes, no, that's quite true. I mean, presumably at that point they have a subtle field arrangement centrally at the point. Yeah, sure.
Yes. In the optic neuritis trial, we know that the steroids can delay the progression of MS for 2 years. What about if the steroid repeated after 2 years? Does it have any effect?
We don't know that because that study was not done. This was not a primary outcome measure of the optic neuritis treatment trial, and the effect wore off at year 3 and was completely gone by year 5.
But you're asking about doing the steroids again, though.
We don't know.
Yeah, but clinically in practice, a lot of people will repulse with steroids as part of their immunomodulatory therapy for patients with true MS that are getting one of the immunomodulatory agents that break through. They'll repulse them with steroids and then continue the agent on with the hopes that that will enhance a little more immunosuppression.
Again, totally hypothetical.
I would be very cautious about secondary and ad hoc analysis or post hoc analysis data that comes out of any clinical trial. If it was not designed as a primary outcome measure, I'm very suspicious of secondary outcome measures that are just produced post hoc or ad hoc, especially with the number of cases that was used to generate that data.
Please, my question about the beta interferon and the treatment with immunomodulator. Are we aware of anything like receptor level study? Who is going to get benefit more than others of treating with interferon beta? The second thing regarding your pair example, is that because of that we don't have oral beta interferon yet, or it's not successful yet? And the third question about the SACATS movement, is that useful in Chinese language because they read vertically? Thank you.
You want to start with the...
I don't know if we have any predictors other than the MR scan. Some people will use this lumbar puncture, oligoclonal and a cervical spine MR to push them towards treating with a immunomodulatory agent. I don't think there's any other predictor. If you look at the optic neuritis treatment trial, patients that, if you had shown me their MRI at onset, I would have said that person's destined for MS, and 15 years later, they don't have it. If you had treated that patient with immunomodulatory therapy, you would be taking credit for preventing multiple sclerosis in that patient, when in reality, we did nothing to them. The reading Chinese letters thing is intriguing to me. I'm interested in what Jason has to say, because there are computer programs that can convert text from horizontal line to a vertical, and it can be read vertically on the screen.
Yeah, I mean, I think from the point of view of the MS issue, first of all, with treating the first episode, from what I remember from the CHAMP study, the difference at 2 years, and of course, you have to remember that, most of the time, if you're waiting, you're not waiting for 2 years. You're waiting until the next hit occurs before you make the decision to start them on treatment. But in that study, the difference between the treated and not treated group after a first episode was 2.2 lesions in the brain. And remember, when we're talking about this, what we're really talking about is long-term cognitive and physical disability. Right? That's what counts for these people. Are they going to be more or less likely to end up in that point? We don't have that kind of data. But to me, I kind of wonder, 2.2 lesions, is that really going to translate to a meaningful difference in terms of cognitive physical disability in terms of pushing people to starting earlier? I kind of doubt it. The reading, if you read vertically, you're home free. Hemianopia is not going to be a big issue for you. But if you develop an altitudinal defect, then you're going to have some real problems. It's very interesting, the way in which language direction of reading affects some of these cognitive issues we see, not only with things that are obvious like alexia, but also with things like line bisection. We all do line. Everyone knows what line bisection is. You give them a line, you say put a line where the middle of it is. It's one of the most common behavioral neurology kind of tools that people use to try and diagnose neglect. That's influenced by whether you live in a culture that reads left to right or right to left.
Can I ask you, Jason, why patients don't just go like this? Why don't they just take their material and go like this?
I tell them, and I think very few of them really do it because it's not that easy. It takes practice. And I think I live with a bunch of lazy patients. So, I need to go to their homes and kick them to make sure that they try to, even the kind of obvious, you're somebody who has a quadrantic defect, right? It's just the lower quadrant of the central 5 degrees is taking the hit. All they have to do to get around that lower quadrant defect is don't hold it tight like this, hold it like that. you think they do it? Well, some of them have, and it has worked. But it's like it's hard for them to believe that something that simple and that stupid could actually help. I think sometimes it's, you have to be able to sell the idea that this is actually worth training. I have a subject right now with hand-me-optic dyslexia who I am training to read vertically, and he's plugging away. My problem, though, is I suspect he has an element of alexia, pre-alexia as well, and that's not going to be helped by doing that.
Can I ask you something else? How come they don't turn their head if they're on a homonymous hemi-up like this?
Sorry, I didn't get it.
I can't see over there. I just move my whole field this.
Well, you don't have to turn your head to do that. You just turn your eyes, no?
No, just turn your head so that your field, instead of it being over there, it's over here now.
But your field defect is a retinotopic. It's not a craniotopic.
But in children, the patients with the homonymous hemianopsia, a lot of them have this head compensatory posture to keep from running into stuff.
Oh, but that's also because, why would that be? That's because they're trying to extend the range of the saccadic thing. Well, Pages is not the range so much, it's just a central vision, right? So trying to see your far periphery by changing your head position isn't going to help you if all you're trying to struggle with is that little itty bitty bit right in the middle of your field.
Regarding the presentation of optic atrophy, what is helpful clues to differentiate physiological optic power and optic atrophy in children, especially sometimes it's very difficult to examine the pupil and practically it is difficult to do visual field examination for children. Thank you.
Yeah, it's always a problem when you have a child when you don't have any of the subjective tests, and if you say, well, it's bilateral, I can't check the pupil because both eyes are affected. I don't know what your experience with OCT has been in this country, but OCT has made it a lot easier for me to just say, you have a normal nerve fiber there. It's a lot easier for me to follow those patients quantitatively over time.
In the management of ischemic optic neuropathy, is there any role for hyperbaric oxygen?
This was looked at by one of our colleagues, Tony Arnold, and there was no benefit to the use of hyperbaric oxygen in non-autolytic AION.
I have a question about the reading difficulties. We know from neurology that Wernicke aphasia, they can present with reading difficulty. Are you aware of any isolated reading difficulties due to Wernicke aphasia?
Well, yes, but by definition, those people would have more than just alexia, right? They would have the problem with comprehension of verbal language. So, in general, most people with Wernicke's aphasia don't present with a complaint of reading problems, partly because they can't tell you that. They have that empty, verbose kind of speech that kind of runs on and on, and usually are more likely to be misdiagnosed as confusion than as an alexia. Right. So when I talk about the reading difficulties here, I'm really talking about people who don't have any kind of auditory or verbal language deficit because they're able to kind of express their complaint.
We note that those cases that present with recurrent optic neuritis, the later attacks usually they don't go back to their baseline vision, and the more repeated attacks, the more they lose vision. This implies more destruction of optic nerve fibers. I was just wondering that now, since we have the OCT of the optic nerve, whether using IV steroids in the beginning would lessen the chance of losing more optic nerve fibers.
Yeah, it's a very interesting question, isn't it? Because after all, when all the ONTT stuff is based upon just a single attack, and as long as you have enough reserve, your visual function recovers, but maybe subclinically, there isn't the complete recovery. The axons have taken a hit, your reserve is down, and you're going to be vulnerable if you have attacks. So yes, there's a good hypothetical argument for suggesting that maybe there is a role for trying to limit the damage, but then we would need a trial to show that it actually does that. That's probably the ONTT was done in the days before OCT, so we don't really have the information on how effective is it at preserving your axon, your reserve, right?
But what you're raising is the core of the debate on immunomodulatory therapy, which is when I was a resident, I learned demyelination, remyelination. Now we say demyelination, remyelination, yes, but there is axonal loss that is occurring with these attacks. And so some of our colleagues who would be arguing very strongly for immunomodulatory therapy would be saying, how much brain are you willing to lose while you're waiting for the clinically definite MS to show up because you are having axonal loss? So in my opinion, there is a rationale for treating recurrent attacks with intravenous steroids with the goal of prevent axonal loss.
Yeah, we just really don't know yet how effective that is. I think one of the things we're starting to see in the MS world is people turning to look to see can they find axon protective agents, right? And maybe using OCT as a way for monitoring that. But that answer presumably is still a few years away.
Yeah, I agree. I think that we should be as proactive as we can in trying to treat patients that have recurrences. I'm getting the look.
No, the issue about OCT is something I'll talk about later, but there's conflicting information about that in MS. There are some papers that show that even without subsequent attacks of optic neuritis, you slowly lose retinal axons, and your retinal nerve fiber layer gets thinner. Whereas there are other papers that say, although it was over a short period of time, 6 months, that doesn't happen. So whether OCT is going to be a biomarker for progression and axonal loss in MS is still something that's being worked out. But the drug companies are putting a lot of money into this because almost every study that I know of any new drug in MS has an OCT arm to it.
Can I ask one small question? Is it routine in your practice for non-arthritic ischemic optic neuropathy to do gonioscopy?
To do
all over gonioscopy. Gonioscopy to see the angle. We do measure intraocular pressure routinely as
I measure intraocular pressure, but I don't think I've ever done gonioscopy unless on slit lamp exam the chamber looks shallow.
I don't either in the Western population, but in the patients that from the Middle East, there are a lot of anomalous angles and a lot of shallow anterior chambers. So I'm much more cautious in this population, but otherwise, no.
Why I'm raising this point? Because we know that glaucoma is one of the risk factors for non-ischemic optic neuropathy. What happens that I have seen a few cases, they come, we investigate them as non-ischemic optic neuropathy, we check the intraocular pressure and it's normal. Later on, they come with angle closure glaucoma. So this makes me suspect whether those people are subjected to subacute angle closure, probably at night or when the pupil is dilated, that predisposed to this condition.
Well, you would hope that somehow in your history you could pull out something that would make you think more of that. But in general, no, it is not part of our practice.
Okay. Thank you.
Okay, so it will be the last question.
My question about the difficulties of diagnosing giant cell arthritis. I saw a lot of patients, all are old with systemic diseases like hypertension, diabetes, hypercholesterolemia, and they have only headache, no joint lubrication, no scalp tenderness or other manifestation of giant cell arthritis. On doing blood test, they have elevated C-reactive protein, because this could be elevated in diabetic patients. By chance, or by the way, they may have elevated ESR, but not to high levels. On palpation of superficial tender arteries, not maybe suspicious, but it's not viewed like typical giant cell arthritis. So what's your suggestion of those patients? Is it do biopsy or if there is any other diagnostic tools like fluorescein angiography?
One of the problems that I had at Wills Eye Hospital was in July, when the new residents started. I would give them lectures and say, remember, central retinal artery occlusion and double vision could be a sign of giant cell. And at 3 o'clock in the morning, I'd get a call, and they'd say, I have this patient with a 6th nerve palsy and diabetic, and I said, don't tell me, you did a SED rate. And they said, well, you told us to think about giant cell. I said, think about giant cell, don't do a blood test. It's like what Andy said. You don't do the blood test unless you have a clinical suspicion. So what I tell them is ask the questions and write down. The patient has no scalp tenderness, no jaw claudication, no other signs suggestive of polymyalgia rheumatica or giant cell arteritis, and therefore you don't have to do, and you shouldn't do, the blood test, because you're absolutely right. In that population, you're going to find abnormal blood tests. And once you've got the abnormal blood test, I think you are duty-bound to put the patient on steroids and do a temporal artery biopsy.
You know, I know that there are 12 cases in the world literature of ocular motor palsies with giant cell arteritis, and I know that because I saw one patient in my career a few years ago that presented with a 6th nerve palsy. I was seeing him for the first time, and in the course of a very, very long history, we got a lot of positive things, and amongst them were things that sounded like giant cell. So somewhere in working that up, I said I should do a SED rate and a CRP on this patient, but I didn't really know her well, and I just wasn't sure what her real, status was. And it was a busy day, and I didn't check the SED rate CRP till the next day, and I checked it, and her SED rate was 100. And I called her up, and she said, I was going to call you because I lost vision in one eye last night. And so it doesn't make me change anything. I still don't do it for 6th nerve palsies, but as you live and breathe, you always will get a surprise in your medical careers.
I just wanted to add that pre-test likelihood of disease, your clinical suspicion, is the most powerful predictor of post-test likelihood of disease, independent of the sensitivity and specificity of the test you're going to perform. So if you don't think they have giant cell, don't order the test, as Peter says. But if you do think they have giant cell and the test comes up normal, don't ignore the patient. Throw away the lab test, don't throw away the patient.
That's the clinical suspicion point again. Yeah.
Well, just as an aside, you can make the sensitivity and the specificity of the test anything you want, because you can alter the threshold by which you will take action. So if you say, look, any SED rate over 40 or 30, I'm going to consider giant cell. Well, you just increased your sensitivity a lot, but your specificity just went down. If, however, you say, I'm only going to accept a SED rate of 100, if it's not 100, I'm not going to biopsy the person. Well, your specificity just went way up, but your sensitivity for capturing the disease went way down. So you can make it whatever you want, depending on what lab value you choose to accept as normal for your SED rate or CRP. That's why pretest likelihood of disease is way more powerful. Because if the pretest likelihood of disease is 90%, even a test that has 99% sensitivity and specificity, the post-test likelihood of disease in a person who has a pretest of 99% is only 80%. They don't know how to do it. They probably still have it.
How much should we are stem cells for relating and inflammation investigations?
Don't hold your breath.
One question about the optic neuritis in children. They usually came with severe headache and bilateral optic neuritis, and when we do LB, it shows high intraocular pressure. So, shall we treat them as BIH or and keep them on steroid, and how long, or add Dimox with it?
Yeah, many of my patients, I'm interested in what Pam and maybe Jason sees, some of these patients see with ADEM have increased intracranial pressure, which partially accounts for why the appearance of the disc is not the same as routine optic neuritis, because they have multifactorial mechanisms for their optic neuropathy. So if they have enhancement of their nerve, I'm going to give them intravenous steroids. If they have high pressure but no enhancement, I'm going to give them intracranial hypertension agents. Diamox is usually what we use. And if they have both, we're going to do both. So I don't think there's any correct answer, but mostly the vision loss is from optic neuropathy, from direct inflammatory disease of the optic nerve. It's the patients that have high intracranial pressure but no enhancement that I get really super aggressive on intracranial pressure monitoring and management.
In fact, I would go a step further than that. You do not see visual loss from increased intracranial pressure that's acute. And if you remember the slide of the fundus that Andy showed, it was acute disc swelling. So that there is no confusion between, and there is no such thing as far as I'm concerned as BIH. There's nothing benign about pseudotumor cerebri or IIH, but it's always acute papilledema does not cause visual loss to the point where the kids who have optic neuritis have visual loss. Even if the pressure is elevated, it's still the optic neuritis that's causing the problem, not the increased intracranial pressure.
I would be inclined to treat that aggressively and not to add a Diamox on. I don't want to add anything on that's going to make the patient hemoconcentrated any more than the steroids do. So I would treat what I know is a disease and trust that that's going to take care of the increased pressure. Patients with Guillain-Barré will get increased pressure because of decreased respiration, CO2 retention. There can be a lot of reasons for increased pressure, and so you treat the reason.
By this, can we leave? By this, we have to end our second session for today, and we'll go now for lunch, coming back at 2:15. Thank you.